Hello. For this video, I will discuss cardiovascular physiology. At the end of the video, I hope that you, the students, would be able to discuss the function of cardiovascular tissues and explain their functional relationships. And also, I expect that you should be able to explain the physiologic mechanisms of the cardiovascular system. Review of the heart anatomy. The heart is about the size of the fist. It is a hollow cone shape that has a mass of 250 to 350 grams. It is located snugly enclosed within the mediastinum or the medial cavity of the thorax. The heart extends obliquely for 12 to 14 centimeters from the second rib to the fifth intercostal space. Between the fifth and sixth ribs, just below the left nipple, you can easily feel the heart beating where the apex contacts the chest wall, and this site is said to be the point of maximal intensity. Structure and function of the heart. The heart is surrounded by three layers. First is the pericardium. The pericardium has two distinct layers. You have the fibrous pericardium and the serous pericardium. The fibrous pericardium is a dense connective tissue layer that protects the heart, anchors it to surrounding structures, and prevents the overfilling of the heart with blood. The serous pericardium, on the other hand, has a two distinct layer of serous membrane, the outer parietal layer and the inner visceral layer called the epicardium. Pericardial cavity is seen between the parietal and visceral layer. It contains a film of serous fluid, and the serous membranes are lubricated by this fluid so that the heart can easily glide smoothly during heart activity, allowing the heart to be freely mobile to work in a relatively friction-free environment. Myocardium is another layer in the heart. It is composed mainly of cardiac muscle, and it forms the bulk of the heart. In this layer of the heart, you can find cardiac muscle cells that are tethered to one another by crisscrossing connective tissue fibers and arranged in spiral or circular bundles that links all parts of the hearts together. The innermost layer is the endocardium, which is a glistening white sheet of endothelium composed of squamous epithelium that rests on a thin connective tissue layer. It lines the heart chambers and covers the fibrous skeleton of the valves of the heart, and it is continuous with the endothelial linings of the blood vessels leaving and entering the heart. This picture illustrates the three main layers of the heart: the pericardium, the outermost layer, the myocardium, which is the thickest layer of all, and the innermost layer is the endocardium. Again, the pericardium has two distinct layers: the fibrous pericardium and the serous pericardium. And the serous pericardium has also two distinct layers: the outer parietal layer and the inner visceral layer. In between the serous pericardium, there is a pericardial cavity that contains pericardial fluid that allows freely movement of the heart without friction. The heart is also consists of four chambers: the two superior atria and the two inferior ventricles. The atria are considered to be the receiving chambers, and the ventricles is said to be the discharging chambers. The right atrium receives the impure or deoxygenated blood from the body via superior vena cava, inferior vena cava, and coronary sinus. The right ventricle receives deoxygenated blood from right atrium via right atrioventricular orifice and sends it to the lungs via pulmonary trunk. On the left side, the left atrium receives the oxygenated blood from the lungs via pulmonary veins, which is one of the veins that is exempted to the rule. pulmonary veins carries oxygenated blood rather than deoxygenated blood. Left ventricle receives oxygenated blood from left atrium via left atrioventricular orifice and sends it to the body via aorta. Right atrium. The interior of the right atrium is divided into two parts, the smooth posterior part and the rough anterior part. The smooth posterior part is also called the sinus venarum because all the veins except anterior cardiac veins open into this part. Some of the veins that opens in this part is the superior vena cava, inferior vena cava, coronary sinus, and vena cordis minimi. Rough anterior part of the right atrium presents number of muscular ridges, the musculi pectinati, which arise from crista terminalis and runs forwards towards the auricle. The two parts, the smooth posterior part and rough anterior part, is separated from each other by a crista terminalis. The interior of right atrium also presents a septal wall on the right atrium, which has a shallow depression called the fossa ovalis. This fossa ovalis is a shallow oval depression in the lower part of interatrial septum, and it marks the site of the foramen ovale, which is an opening in the interatrial septum of the fetal heart. This illustrates the right atrium. You have the fossa ovalis. Again, it is a shallow depression that marks the foramen ovale, which is an opening only seen on fetal heart. Atria. Blood enters the right atrium via three veins, the superior vena cava that returns blood from body regions superior to the diaphragm, the inferior vena cava that returns blood from body areas below the diaphragm, and the coronary sinus that collects blood draining from the myocardium or from the heart itself. Four pulmonary veins enter the left atrium, which makes up most of the heart's base. These veins, which transport blood from the lungs back to the heart, are best seen in posterior view, and the only veins that carries oxygenated blood. In atria, you can also find some anatomical landmarks like the auricles, which are small wrinkled protruding appendages found in the atria. Interatrial septum, which serves an internal partition between the two atria, interventricular septum that separates the ventricle, and the coronary sulcus or atrioventricular groove that is visible on the heart surface indicates the boundaries of its four chambers and carry the blood vessels supplying myocardium, and also it encircles the junction of atria and ventricles like a crown. Ventricles. Ventricles are also called as discharging chambers of the heart. The right ventricle forms most of the heart's anterior surface, and the left ventricle dominates its postero-inferior surface and form its apex. So, marking the internal walls of the ventricular chambers are irregular ridges of muscle called trabeculae carneae. The cone-like papillary muscles, which play a role in valve function, projects also in the ventricular cavity. The right ventricle pumps blood into the pulmonary trunk, which routes the blood to the lungs where gas exchange occurs. The left ventricle, on the other hand, injects the blood into the aorta, which is the largest artery in the body, and it goes to the different parts of the body. Heart chambers. So, in this picture, you can see the difference between right and left ventricle. So, The right ventricle has a thinner wall compared to the left ventricle. Its myocardium is 3 times thicker than the right ventricle. The cavity is crescentic shape in right ventricle, and it's very oval shaped in left ventricle. The right ventricle has 3 papillary muscle and the left ventricle only has 2. The chordae tendineae in left ventricle are more long compared to the right ventricle. And also, atrioventricular orifice is guarded by bicuspid valve or mitral valve in left ventricle, and the atrioventricular orifice is guarded by tricuspid valve in right ventricle. The heart valves. Atrioventricular valves is located at atrial ventricular junction. It prevents the backflow of the blood into the atria when the ventricles are contracting. So the right AV valve or the tricuspid valve has 3 flexible cusp, while the left AV valve with 2 flaps is called the mitral valve because of its resemblance to the two-sided bishop's mitre or hat. It's sometimes called bicuspid valve because it has only 2 flaps. Semilunar valves. The aortic and pulmonary semilunar valves guards the base of the large arteries issuing from ventricles, the aorta and pulmonary trunk, and they prevent backflow in the associate ventricle. Each semilunar valve is fashioned from 3 pocket-like cusps, each shaped roughly like a crescent moon. That is why it is called semilunar valves. So all of the heart valves in the body, both the atrioventricular valve, the AV valve, and the semilunar valves, all of these valves functions to prevent the backflow of the blood all throughout the heart so that the oxygenated blood and the oxygenated blood will not mix together. This is a cross-sectional picture of the heart. So as you can see, the 2 semilunar valves, the aortic semilunar valve and the pulmonary semilunar valves, the 2 atrioventricular valve, the tricuspid valve on the right side of the heart, and the bicuspid valve or mitral valve on the left side of the heart. Atrioventricular valve function. The blood returns to the heart and it fills the atria, putting pressure against AV valves, and when the pressure is against these AV valves, it is forced to open. When it is open, the ventricles is filled with the blood. Upon atria contraction, it forces additional blood going to the ventricles. When the ventricles contract, it forces the blood against the atrioventricular valves, closing it forcefully. The papillary muscle contract and chordae tendineae tighten, preventing the valve flaps from everting into the atria. Thus, the function of the atrioventricular valve is to prevent the backflow of the blood from the ventricles going again to the atria. Function of semilunar valves. As the ventricles contract and intraventricular pressure rises, the blood is pushed up against semilunar valves, forcing them to open. As the ventricles relax and intraventricular pressure falls, the blood flows back from arteries, filling the cusp of semilunar valves and forcing them to close. Thus, the true function of the semilunar valves is to prevent the backflow of the blood, from the aorta and pulmonary trunk going again to the ventricles. Note that when the semilunar valves close, it marks the second heart sound. Blood supply of the heart. Arterial supply of the heart is provided by the right and left coronary arteries. that both arise from the base of the aorta and encircling the heart in the coronary sulcus. Coronary circulation is the functional blood supply of the heart, and it is the shortest circulation in the body. The coronary arteries, right and left coronary arteries, provide an intermittent, pulsating blood flow to the myocardium. These vessels and their main branches lie in the epicardium and send branches inward to nourish the myocardium. They deliver blood when the heart is relaxed, and they are fairly ineffective when the ventricles are contract because they are compressed by the contracting myocardium. Left coronary artery runs towards the left side of the heart, and it has two major branches: the anterior interventricular artery, known as left anterior descending artery, the circumflex artery. All of this supplies the left portion of the heart. The right coronary artery courses the right side of the heart, where it divides into two main branches: the marginal artery and the posterior interventricular artery. There are many anastomoses among the coronary arterial branches, and these fusing networks provide additional or collateral routes for blood delivery to the heart muscle. But they are not strong enough to supply adequate nutrition when a coronary artery is suddenly occluded. Coronary artery occlusions leads to complete blockage, leads to tissue death, and usually heart attack. So when there is an occluded coronary artery, the patient is usually prescribed with blood thinners so that the blood can easily flow through this occluded coronary artery, or if the occlusion is so severe, surgical intervention is strongly recommended. Venous drainage of the heart. Cardiac veins collects the venous blood passing through the capillary beds of the myocardium. These veins join together to form an enlarged vessel called the coronary sinus. The coronary sinus empties the blood into the right atrium. It has three major tributaries: the great cardiac vein, the middle cardiac vein, and the small cardiac vein. Additionally, several anterior cardiac veins empty directly into the right atrium anteriorly. The blood vessels carry blood to and from the lungs, form the pulmonary circuit, which serves for gas exchange. The blood vessels that carry functional blood supply to and from all the body tissues constitute the systemic circuit. The right side of the heart is the pulmonary circuit pump. The blood returning from the body is relatively oxygen poor and carbon dioxide rich, sometimes termed as the oxygenated blood. It enters the right atrium and passes into the right ventricle, which pumps it to the lungs via pulmonary trunk. In the lungs, the blood unloads the carbon dioxide that is exhaled by the body and picks up oxygen, which is inhaled from the outside environment. The freshly oxygenated blood is carried by the pulmonary veins back to the left side of the heart. On the other hand, the left side of the heart is the systemic circuit pump. The freshly oxygenated blood leaving the lungs is returned to the left atrium and passes into the left ventricle, which pumps it into the aorta. From there, the blood is transported via smaller systemic arteries to the body tissues, where gases and nutrients are exchanged across the capillary walls. After the oxygen is consumed, the blood once again loaded with carbon dioxide and depleted of oxygen. It now returns through the systemic veins to the right side of the heart, where it enters the right atrium through the superior and inferior vena cava. Although equal volumes of blood are pumped to the pulmonary and systemic circuits at any moment, the two ventricles have very unequal workloads. The pulmonary circuit, which is served by the right ventricle, has a short, low pressure circulation, whereas systemic circuit, which is served by the left ventricle, takes a long pathway through the entire body and has a high pressure circulation. The functional difference is revealed in the anatomy of these two ventricles. The wall of the left ventricles are 3 times as thick as those of the right ventricle. The right ventricular cavity is flattened into crescent shape and partially encloses the left ventricle. Consequently, the left ventricle can generate much more pressure than the right and is far more powerful pump because it has a thicker myocardium than the right ventricle. The right side of the heart receives oxygen poor blood from body tissues and then pumps this blood to the lungs to pick up oxygen and dispel carbon dioxide. The blood vessels that carry blood to and from the lungs again form the pulmonary circulation. The left side of the heart receives the oxygenated blood returning from the lungs and pumps this blood throughout the body to supply oxygen and nutrients to the body tissues. The blood vessels that carry blood to and from all the body tissues form the systemic circuit. Thus, the pulmonary circuit and systemic circuit forms the circulation of the body. The ability of cardiac muscle to depolarize and contract is intrinsic. In other words, it is the property of the heart muscle and it does not depend on the nervous system, unlike the skeletal muscle. Even if all nerve connections to the heart are severed, the heart continues to beat arrhythmically as demonstrated by transplanted heart. So, although a healthy heart is amply supplied with autonomic nerve fibers that can alter its basic rhythm, it has the ability to contract by itself. So, the independent but coordinated activity of the heart is the function of its intrinsic conduction system. The heart's intrinsic conduction system is due to the presence of gap junctions and the activity of the heart's in-house conduction system. The intrinsic cardiac conduction system is consist of a non-contractile cardiac cells specialized to initiate and distribute impulses throughout the heart so that it depolarizes and contracts in an orderly sequential manner. Cardiac pacemaker cells or orthorhythmic cells makes up the intrinsic conduction system. They have an unstable resting potential that continuously depolarizing, drifting slowly towards threshold. Pacemaker potentials or prepotentials are the potentials that initiates the action potentials that spread throughout the heart to trigger its rhythmic contractions. These pacemaker potentials or prepotentials are made by these cardiac pacemaker cells or orthorhythmic cells. So let's take a look on this picture. This is a line graph of a cardiac muscle action potential. Unlike the skeletal muscle action potential, which has a latent period, an action potential, and a resting period, as you can see here in the line graph of a cardiac muscle, there is this pacemaker potential that increases the membrane potential, making it more or slightly positive than usual before the main action potential. So after that, it goes to the third phase, which is the resting phase, but then again, it increases space, it increases membrane potential again because there is a slow rest or simply no rest at all due to this cardiac pacemaker cell making another pacemaker potential. Pacemaker potential is due to the special properties of the ion channels in the sarcolemma. In the cells, hyperpolarization at the end of an action potential both closes potassium channels and opens those sodium channels. Take note that one of the difference between skeletal muscle and cardiac muscle is their hyperpolarization. In skeletal muscle, the hyperpolarization is due to the delay closing of the potassium channels. Wherein in cardiac muscle, the hyperpolarization is due to the closing of potassium channels and open slow sodium channels. When the sodium channel opens, it alters the balance between the potassium loss and the sodium entry. And the membrane interior become less and less negative, meaning becoming more positive. So, here in cardiac muscle, hyperpolarization happens, but it does not prolong because there is an opening of a slow sodium channel that alters the hyperpolarization caused by closing of potassium channels. After pacemaker potential, there is depolarization. So depolarization, ultimately when a threshold caused by a pacemaker potential, depolarization happens because the calcium channels open, allowing explosive entry of calcium from extracellular space. Another difference between skeletal muscle and cardiac muscle is that the depolarization in cardiac muscle cells happen because there is a calcium channel opening. So remember that calcium is also a cation, which means it has a positive charge. The opening of these calcium channels cause the calcium to enter the cell from the extracellular space. As a result, in pacemaker cells, it is the influx of calcium rather than sodium that produces the rising phase of the action potential and reverses the membrane potential. Repolarization, as in other excitable cell, falling phase of action potential and repolarization reflects the opening of potassium channels and the potassium efflux from the cell, meaning repolarization of the cardiac muscle cell is the same with the other excitable cell because repolarization happens because potassium goes out of the cell. Sequence of excitation. So the cardiac pacemaker cells are found in the following areas. You have the first, the sinoatrial node, which is what we know as the pacemaker of the cell because it is the first one to generate the impulses within the heart. After the impulse is generated by the sinoatrial node, the impulse pause about zero point 0.1 second and initiates impulses to the atrioventricular node. This atrioventricular node then passes these impulses to the AV bundle or the bundle of His that connects the atria to the ventricles. The bundle branches conducts the impulses through the interventricular septum, and this bundle branches transfer the impulses to the subendocardial conducting network or Purkinje fibers that depolarizes the contractile cells of both ventricles. Sequence of excitation. Sinoatrial node is a crescent-shaped node that is located on the right atrial wall just inferior to the entrance of the superior vena cava. This sinoatrial node typically generates the impulses about 75 times every minute. The SA node sets the pace for the heart as the whole because no other region of the conduction system or the myocardium has a faster depolarization rate. For this reason, it is the heart's pacemaker. It is called the pacemaker of the heart because its conduction defines the characteristic rhythm of the heart, which is called the sinus rhythm. And this sinus rhythm also determines the heart rate. Atrioventricular node. From SA node, the depolarization waves spread via gap junctions throughout the atria and via the internodal pathway to the atrioventricular node. At the AV node, the impulse is delayed for about zero point 0.1 seconds, allowing the atria to respond and complete their contraction before the ventricles contract. Why is it that we need a delay for the impulses from the SA node to atrioventricular node? There should be a delay for the impulse to travel from SA node to AV node because if there's no delay, atrium and ventricles will have the same contraction time. Thus, the oxygenated blood and deoxygenated blood can mix up together. So this delay reflects the small diameter of the fiber here and the fact that they have fewer gap junction for current flow. Consequently, the AV node conducts impulses more slowly than the other parts of the system. Once through the AV node, the signaling impulse passes rapid through the rest of the system. So, there is only a delay of impulses, of transfer of impulses from the SA node to the AV node. But after that, the the generated impulses from the AV node to the next sequence is just the same. Atrioventricular bundle or bundle of His sweeps the impulses from the atrioventricular node to the ventricles. So, although the atria and ventricles abut each other, they are not connected by gap junctions. So, the one that spreads or connects the impulses from the atrium to the ventricle is this atrioventricular bundle or bundle of His. The AV bundle is the only electrical connection between them. The fibrous skeleton is non-conducting and insulates the rest of the AV junction. So, the atrioventricular bundle or bundle of His is located in the superior part of interventricular septum. Right and left bundle branches. So the AV bundle persists only briefly because they split into two pathways, the right and left bundle branches, which course along the interventricular septum towards the heart's apex. Subendocardial conducting network, also called as Purkinje fibers, completes the pathway through the interventricular septum, penetrates into the heart's apex, and then turns superiorly into the ventricular walls. The bundle branches excite the septal cells, but the bulk of the ventricular depolarization depends on the large fibers of the conducting network and ultimately on cell-to-cell transmission of impulse via gap junction between the ventricular muscle cells. So because the left ventricle is much larger than the right, the subendocardial conducting network is more elaborate in that side of the heart. Although the intrinsic conduction system sets the basic heart rates, the fibers of autonomic nervous system modifies its march-like beat and introduce a subtle variability from one beat to other beat. So this autonomic nervous system composed of sympathetic and parasympathetic nervous system modifies the basic rhythm of the heart. The sympathetic nervous system serves as an accelerator that increases the both rate and force of heartbeat. The parasympathetic nervous system serves as a brake that slows the heart. As you can see here in this picture, the cardioacceleratory center is located in the medulla oblongata, and the cardioinhibitory center is located to the dorsal vagus nucleus in the medulla. Electrocardiography. The electrical currents generated in and transmitted through the heart spread throughout the body and can be detected with a device called an electrocardiograph. An electrocardiogram is a graphic record of the heart's activity. So a typical ECG has three almost immediately distinguishable waves or deflections: the P wave, the QRS complex, and the T wave. So, first is the P wave. As you can see in this picture, it is a small wave that lasts about 0.08 seconds and result from the movement of the depolarization wave from SA node through the atria. Approximately zero point 0.1 seconds after the P wave begins, the atria contracts. The large QRS complex results from the ventricular depolarization and precedes ventricular contractions. After the QRS complex, the T wave. The T wave is caused by ventricular depolarization, typically lasts about 0.16 seconds. So again, the P wave is caused by the atrial depolarization initiated by SA node. So this is the one that causes the P wave, atrial depolarization initiated by the SA node, which is the pacemaker of the heart. So with atrial depolarization is complete, the impulse is delayed at the AV node. As you can see here, that's why the line graph is flattened, because there is delay from the impulses from SA node to the AV node. So the QRS complex results from the ventricular depolarization and precedes ventricular contraction. It has a complicated shape because the paths of depolarization waves through the ventricular walls change continuously, producing corresponding changes in current direction or average duration of the QRS, which is 0.08 seconds. So as you can see here, QRS complex is caused by the ventricular depolarization, begins at the apex, causing the QRS complex, and also it is not evident, but there is also an atrial repolarization. So again, the P wave usually is the atrial depolarization. The QRS complex is composed of a not so evident atrial repolarization and a very evident ventricular depolarization. Then ventricular depolarization is complete, so there is a line, flat line after the QRS complex. So the T wave is caused by ventricular repolarization that typically lasts about 0.16 seconds. Repolarization is slower than depolarization. So the T wave is more spread out and has a lower amplitude or height than QRS wave because atrial repolarization takes place during the period of ventricular excitation. The wave representing the atrial repolarization is normally obscured in large QRS complex being recorded at the same time. So again, the T wave marks the ventricular repolarization. Then after that, there is a flat line, meaning that the ventricular repolarization is complete. So the PQ interval is the time from the beginning of atrial excitation to the beginning of ventricular excitation. Sometimes the PR interval, because the Q wave tends to be very small, it includes the atrial depolarization, as well as the passage of depolarization wave through the rest of the conduction system. ST segment of the ECG is when the action potential in its plateau phase, the entire ventricular myocardium is depolarized. So, the QT interval naman, on the other hand, lasts about 0.38 seconds, and it is the period from the beginning of ventricular depolarization through ventricular repolarization. So, I just want you to know, focus to the PQRST wave. So these segments are, or intervals are, used by the physicians or cardiologists to really define what's the problem in the heart. Heart sounds. So the first heart sound occurs when the AV valves close. It signifies the point when ventricular pressure rises above atrial pressure beginning of systole. The first sound tends to be louder, longer, and more resonant than the second. The second sound occurs as the semilunar valve snap shut at the beginning of ventricular relaxation or diastole, resulting in a short, sharp sound. So the basic rhythm of the heart sounds is lub-dub. So lub-dub, lub-dub, pause, and so on, with the pause indicating the period when the heart is relaxing. So because the mitral valve closes slightly before the tricuspid valve does, and the aortic semilunar valve generally snap shut just before the pulmonary valve, it is possible to distinguish the individual valve sounds by auscultating four specific regions in the thorax. So let's go now to the mechanical events, which is the cardiac cycle. So the heart undergoes some dramatic breathing moments as it alternately contracts, forcing blood out of its chambers, and then relaxes, allowing its chambers to refill with blood. The term systole refers to these periods of contraction, and diastole refers to those of relaxation. The cardiac cycle includes all events associated with blood flow through the heart during one complete heartbeat. Atrial systole and diastole, followed by ventricular systole and diastole. So these mechanical events always follow the electrical events seen in ECG because those electrical events cause the muscles to contract. So ventricular filling is mid to late diastole. So pressure in the heart is slow during ventricular filling. The blood returning from the circulation is flowing passively through the atria and the open AV valves into the ventricle. So why is it that there is low pressure when there is an open AV valves? Because due to the pull of gravity, the blood slowly, or so sorry, it rushes from the atrium to the ventricles. So, and the aortic pulmonary valves are closed. So when there is a blood filling the ventricles, is though it slowly increases the interventricular pressure. So More than 80% of ventricular filling occurs during this period, even though take note that even though the atria is not contracting, 80% of the blood fills the ventricle already, because when there is an open AV valve, the blood rushes down to the ventricles because of the pull of gravity. So more than 80% of the ventricular filling occurs during this period, and AV valves flaps begin to drift towards the closed position. So the remaining 20% of the blood is delivered to the ventricles when the atria contract. Now, the stage is set for atrial systole. Following depolarization, the atria contract, compressing the blood in their chambers. So this causes a sudden slight rise in atrial pressure, which propels residual blood out of the atria into the ventricles. Again, when the atria contract, it forcefully uh, it forcefully puts the blood out of the atria going to the ventricle. But it is only 20% of the blood, because during relaxed stage of the atria, the flow freely to the ventricles because the AV valves are open. So at this point, the ventricles are in the last part of their diastole and have the maximum volume of blood that they will contain in the cycle. This amount of blood is called the end diastolic volume. So the EDV, or the end diastolic volume, is the maximum volume of blood um, comes from the ventricular filling. So then the atria relax. After the atria relax, the ventricle starts to depolarize, as seen in the QRS complex. The atrial diastole persists through the rest of the cycle. So when the ventricle starts to depolarize, it is now ready for its ventricular systole, or contraction. As atria relax, the ventricles begin contracting. There was close in on the blood in their chambers, and the ventricular pressure rises rapidly and sharply, closing the AV valves and preventing the blood to go back to the atria. The split second period, when the ventricles are completely closed chambers and the blood volume in the chamber remains constant as the ventricles contract, is the isovolumetric contraction phase. So meaning that the split second that the ventricles are closed chambers and it is full of blood, even though there is an increased pressure, it has the same blood volume. It is called the isovolumetric contraction phase. So, when the ventricular pressure continues to rise, it finally exceeds the pressure in the large arteries issuing from ventricles. The isovolumetric stage ends as the SL, or semilunar valves, are forced open, and blood rushes to the ventricles into the aorta and pulmonary trunk. So as you can see here, in this picture, the 2A represents the isovolumetric contraction phase, wherein the blood comes from the atrium, goes down to the ventricle, and just before the contraction, it fills up the ventricle. As you can see here, rise the it slowly increases the interventricular pressure, thus opening the semilunar valves. When the semilunar valves are open, there is the next stage or phase, which is the ventricular ejection phase. So, when the SL valves are open, the blood can now rush into the pulmonary trunk and the aorta. So isovolumetric relaxation is in early diastole. During this brief phase following the T wave, the ventricles relax because the blood remaining in their chamber refers to as end systolic volume. So although the ventricles contract, there is still remaining blood after contraction. Okay? So the remaining volume of blood at the end of ventricle contraction is called as end systolic volume. So this is no longer compressed, ventricular pressure drops rapidly, and the blood in the aorta and pulmonary trunk flows back towards the heart, closing the semilunar valves, uh, forcing the semilunar valves to close. So, when the blood rushes to the pulmonary trunk and the aorta, it slowly flows backward towards the SL valves, closing it. So, when the SL valves are closed, the blood remaining in the ventricles cannot go to the pulmonary trunk and the aorta. And that volume of blood is called the end systolic volume. Cardiac output. Cardiac output is the amount of blood pumped out by each ventricle in 1 minute. It is the product of heart rate and stroke volume. The stroke volume is defined as the volume of blood pumped out by one ventricle with each beat. In general, the stroke volume is correlated with the force of ventricular contraction. So using normal resting values for heart rate, which is normally 75 beats per minute, and stroke volume of 70 ml per beat, the average adult cardiac output can be computed as cardiac output is equivalent to the heart rate times stroke volume. So the normal adult blood volume is about 5 liters, a little more than 1 gallon. Thus, the entire blood supply passes through each side of the heart once each minute. Cardiac output increases when the stroke volume increases or the heart beats faster or both. So, and also cardiac output decreases when either or both of these factors decrease. Cardiac output is highly variable and increases markedly in response to special demands such as exercising, running to catch a bus, or doing some chores. So, the difference between resting and maximal cardiac output is referred to as cardiac reserve. Regulation of stroke volume. So, the stroke volume represents the difference between the end diastolic volume, the amount of blood that collects in the ventricle during diastole, and the end systolic volume, which is the amount of blood remaining in the ventricle after it has contracted. So the stroke volume can be computed as the EDV minus the ESV. With each beat, each ventricle pumps out about 70 ml of blood, which is about 60% of the blood in its chambers. The three important factors affecting the stroke volume are the preload, contractility, and afterload. Preload is the degree of stretch of heart muscle. Frank-Starling law of the heart, which is a critical factor controlling stroke volume, is the preload. So, according to the Frank-Starling law of the heart, the preload, which is a degree to which cardiac muscle cells are stretched just before they contract, an optimal length of muscle fibers and sarcomeres. So, the maximum number of active cross-bridge attachments is possible between actin and myosin, and the force of contraction is maximal. Cardiac muscle exhibit a length-tension relationship. Stretching cardiac muscles can produce dramatic increase in contractile force. So the preload means the degree of stretch of heart muscle. So when there is an increased degree of stretch in heart muscle, it means that the stretch cardiac or heart muscle can produce increase in contractile force. The more that the heart muscle is stretched, the more it has a contractile force. So the most important factor stretching cardiac muscle is the amount of blood returning to the heart and distending its ventricles, called the venous return. So how does the cardiac muscle stretches? So it stretches when there is an increase of amount of blood returns to the heart, which is what we call as venous return. So anything that increases the volume or speed of venous return, such as low heart rate or exercise, increases EDV and consequently SV, and then contraction force. Again, the preload is the ability of the cardiac muscle to have an increased contractile force. There is an increased contractile force because there is a stretching of the cardiac muscle. The more stretched the cardiac muscle is, the more the increase the contractile force of the muscle. So again, the factor or the reason why the cardiac muscle is stretching is because of the increase of amount of blood returns to the heart from the body, or what we call as venous return. So, as low heartbeat allows more time for ventricular filling, exercise speeds venous returns because of an increased heart rate and the squeezing action of the skeletal muscles on the veins returning blood to the heart. So during vigorous exercise, the SV or stroke volume may double as a result of these factors. Conversely, low venous return, such as might result from the severe blood loss or an extremely rapid heart rate, decreases EDV or end diastolic volume, causing the heartbeat to beat less forcefully and the stroke volume to drop. So we can say that if there is an increase in preload, there is also an increase in stroke volume, thus increasing cardiac output. Next factor affecting stroke volume is contractility, the contractile strength achieved at any given muscle length. Notice that contractility is independent of muscle stretch and EDV. An increase in contractility is due to a greater calcium ions influx to the cytoplasm from the extracellular fluid and the sarcoplasmic reticulum of cardiac muscle cell. Enhanced contractility results in ejection of more blood from the heart, which results to greater stroke volume, hence a lower end systolic volume. So meaning, unlike the preload, which is caused by increase in venous return, the contractility is independent of the muscle stretch and EDV. So contractility is because of a greater amount of calcium ion to go inside the cytoplasm of the cardiac muscle cell. So when there is an increase in contractility, there is an increase in stroke volume, thus there is an increase in cardiac output. So increased sympathetic stimulation also increases contractility of the heart. The sympathetic fibers, as I've said before, is the heart accelerator. It increases the heart rate by increasing the contractility of the heart. So the sympathetic fibers serve not only as intrinsic conduction system of the entire heart, and one effect of norepinephrine or epinephrine binding to its initiate a cyclic AMP, second messenger system that increases calcium entry, which in turn promotes more cross-bridge binding and enhanced ventricular contractility. So if there is an increase in sympathetic stimulation, there will be an increased calcium flowing inside the cardiac muscle cells, thus increasing contractility, increasing the stroke volume, and increasing the cardiac output. So, another factor for affecting the stroke volume is the afterload. So, the afterload is referred to as a back pressure exerted by arterial blood. So, the pressure that must be overcome for the ventricles to eject blood is called the afterload. It is essentially the back pressure exerted on the aortic and pulmonary valves by arterial blood, about 80 millimeter mercury in the aorta and 8 millimeter mercury in the pulmonary trunk. So, in healthy individuals, afterload is not a major determinant of stroke volume because it is relatively constant. However, in those with hypertension, it is important indeed because it reduces the ability of ventricles to eject blood. Consequently, more blood remains in the heart after systole, resulting in increase in end systolic volume and reduced stroke volume. So, the only factor that is reversely proportional to stroke volume is the afterload. So, if there is an increase in afterload, there is a decrease in stroke volume, thus a decrease in cardiac output. So, this ends the lecture video about cardiovascular physiology. Make sure that you read also the book for more information. And if you have questions regarding the lecture, you can just personally message me on Facebook or in the Google Classroom. So, all our dreams can come true if we have the courage to pursue them.